Welcome to Mind Over Matter. Today we're going to talk about mental health services in prisons, and it's a pleasure to welcome Montgomery Brower, who is Director of Forensic Education at Taunton Secure Care, a psychiatrist with some experience and exposure to this field. So maybe we could start with sort of an overview, your sense of how big a problem is it, how many mentally ill people are caught up in the criminal justice system, and then we'll get into issues of what kind of psychiatric services are available for them.
Well, I want to thank you for giving me the opportunity to come and speak with you about these issues. I know that I have a strong sense of mission as a psychiatrist and as a mental health clinician in caring for this population. It is a group of people with mental illness who are greatly in need, and whom I think all of us need to learn as much as we can, both as mental health clinicians who I think increasingly in the future are going to be involved in caring for people who have been mentally ill and been in jails and prisons, and also as a larger community of people concerned about the mentally ill. This is a large and, as I said, very needy group of mentally ill people that are, I think, really now finally coming to the public attention that has long been needed.
Mm-hmm. Okay. Maybe we could elaborate how large and how needy.
Well, there have been many studies done of how many people who are currently incarcerated or in prisons and jails in the United States are mentally ill. And of course, the numbers vary depending on how mental illness is defined. But it ranges from, if you're looking at the most serious diagnoses, schizophrenia, manic depressive illness, serious depression, to at least 10%. And if you extend to a broader definition, up to anyone who has at any time required mental health services within the correctional setting, the numbers go as high as 20%. So a good average figure is 15%, and that pertains throughout the United States. In Massachusetts, there are currently about 9,400 incarcerated men and women. And among the men in the system, the case rate, so that the number of open mental health cases that are currently receiving treatment is about 15%. And for the women, there are about 600 women in the Framingham, Massachusetts Correctional Institution, which is the only women's correctional facility in Massachusetts. And actually 50% of the women in that institution are being seen to one degree or another by mental health services. So in total, in Massachusetts, there are about 2,000 men and women in the state prisons who are currently considered mentally ill and in need of treatment.
Using a fairly strict definition of that term.
That's right.
Okay.
This refers to actual data about cases who are known to be under treatment in Massachusetts right now.
Okay. And you're not just talking, for the record, you're just not talking about people who are unhappy because they got caught.
No, in fact, I think if you extended the definition to the many kinds of psychological stress and suffering and unhappiness that a person could experience in incarceration, you would be talking about even more people who, I think for anyone, even mentally healthy, the challenges of adapting to an incarceration environment are severe. So, as you can imagine, for someone who has a serious or even perhaps only a moderate mental illness, trying to serve time in a stressful environment where there's severe deprivation of all kinds, where there are many threats, really is something that is very difficult.
So if you're being treated by, say, the mental health programs, and we'll have to define those in a little bit, are you in population? Are you in a special facility? I mean, obviously, we need to talk a little bit about Bridgewater State Hospital, because that's a unique place that the Department of Corrections has for men. At Framingham, I assume if you're a psychiatric patient, you're in general population. There's no sequestered or specialized program for women?
Well, actually, no. One of the recent innovations that's been introduced to the Massachusetts system is one that has been established in other areas of the country as well, which is a so-called residential treatment unit. And this is sort of the equivalent of a day treatment or a residential day treatment program in the community. The community in this case is inside the facility, but what you have is a special part of the facility that is set aside where those whose mental illnesses are severe enough to need pretty much constant care are housed. These units have specialized staffing, both with respect to mental health clinicians and also correctional officers, so that you have a correctional officer staff that generally does not rotate shifts, as is typical, so that the group of inmates who are housed in this residential treatment unit can develop longer-term relationships with the correctional officers. Similarly, the correctional officers can have an experience of understanding in a more ongoing way how to work with these mentally ill inmates. In addition, you have structured programming for the inmates within the residential treatment unit. They attend groups. They have regular contact with case management within the facility, so they have some identified clinician that they can work with. And then, of course, they have particular services delivered by psychiatrists and psychologists.
How about the men? Is there something similar?
Framingham has an RTU for women, and then there are two facilities for the men in Massachusetts right now. One is at Gardner, and one is at Old Colony, which is part of the larger Bridgewater Correctional Complex.
And these are, but these are day programs for people in those specific facilities.
That's right. There has been some discussion of movement within the system of patients who are mentally ill, of inmates who are mentally ill, cannot be in general population because of impairments related to their illness, but don't need the hospital level of care that's offered by Bridgewater. And right now, if that movement takes place, it usually happens because someone has been referred to Bridgewater, has a period of treatment within Bridgewater, and then may be reclassified to one of the facilities that has an RTU, that is a residential treatment unit, because they're considered more appropriate for that level of services.
But just again to clarify, so nobody at Norfolk, for example, is going to get in a bus and go to the Gardner Day Treatment Program. I mean, you don't travel between facilities.
That hasn't taken place yet, but I think that it's, in my experience in discussions within the system, something that's seen as a goal.
Okay. Okay. And what does it take to get transferred to the state hospital? You've defined that as a higher level of care. What are the criteria for admission to Bridgewater State Hospital? Let's stay for the moment not with court-ordered referrals, but with people who are in the correctional system who might get transferred to Bridgewater.
Although I think it's worth commenting just a little bit about the court process, because I think that something very important that happened in mental health law several decades ago at this point was establishing that an inmate in a prison could not be arbitrarily committed to a mental health facility, that in order for someone who was incarcerated and serving time for the commission of a crime to be committed to a mental health hospital, which was viewed as stigmatizing even for those within the correctional population, a court does have to approve that transfer. And there has to be some kind of evidence placed before a court that suggests that indeed the person is in need of commitment to a hospital for treatment.
That's for commitment, not for the initial transfer.
Even for the initial transfer, that has to, there's legal process that is required. However, as a practical matter, the reason that inmates will end up being transferred from correctional facilities to Bridgewater for treatment is usually because they are experiencing symptoms that are so severe that they can't maintain control of their behavior enough, or they can't participate enough in basic daily prison routine to be able to be treated effectively in the prison. You could think of it really as analogous to the inpatient-outpatient model in the community. These days, in order to get into any kind of a psychiatric inpatient treatment setting, you have to really be quite acutely ill and unable to accept or access treatment out in the community. And so it's really an analogous situation with the state prisons and Bridgewater.
Okay, so a 12, for example, is the civil commitment, and you'd be a danger to yourself or others. So you're suggesting the 18A transfers are similar. You have to be a danger to yourself or others.
Actually, the criterion is whether or not you are able to serve time. In other words, being a risk of harm to yourself and others would be obviously a reason why you might not be able to be safely managed in a regular correctional facility, although there are patients who have depression and suicidal ideation who can be safely treated within prisons.
Okay, we're going to have to take a break. I'm sorry to interrupt you. Maybe we can get back to that and then look at the array of services that are available, but we need a break. Thank you.
As time flows on, there are places we return to again and again. Places that comfort us with their serenity. Places that astound us with their beauty. Places where our memories come to life. Precious places, timeless places, places that with your help can endure forever. I'm Paul Newman. Help the Nature Conservancy save the last great places around the world.
To be a mother, you must know these things. How to hold your baby, feed and care for your baby, but most important, how to be there for your baby. If you die while giving birth, you can't be there. And if you die, chances are your baby will too. So if you or someone you love is pregnant, see a healthcare worker and be prepared to take action if you see any of these signs: bleeding, severe headache or fever, if your waters break even a little, if your birth pains last more than a day, Get to a health care worker immediately, because before you can hold and comfort and love, before you can care for your baby, you must first care for yourself. The Safe Motherhood Initiative, because our mothers are our future.
All right, well, let's go back to the prisons for a moment. There was some concern, especially after Salvi's suicide, about screening. So how does somebody's psychiatric situation become known to the caring system? What kind of screening is in place?
Well, it's not just the Salvi situation within Massachusetts, but indeed nationwide. It's become a matter of constitutional law, really, and the interpretation of the courts, that there must be screening for symptoms of mental illness when people come into the correctional system. And so typically what will happen, first of all, in many cases, mental illness will already have been identified as a problem prior through the person's experience in the court system, perhaps where they may have been held pretrial at some point. But regardless, every person who's coming into the correctional system receives a basic health screening, and that includes sitting down with a mental health clinician and going over, or with a nurse, and going over questions that are designed to establish whether or not there might be an issue of mental illness. And although I can't quote any statistics, from my experience in the system, I had the impression that this screening was at a high level of alertness, and that it was unusual for someone to come into the state prison system who had issues of mental illness and not to be identified early on. The jails are another issue. As you may be aware, in Massachusetts, the jails and the houses of correction where people are held either awaiting trial or where they serve relatively short sentences, that is, usually less than 2 years, those jails and houses of correction are administered at the county level by the sheriff's departments. And that is a separate system from the Department of Corrections, so that mental health care is facility by facility, county by county in that system. The requirements and expectations as far as the courts are concerned are the same, but I think there's more variability. And when it comes to the highest risk situations, for example, suicide, for people coming into jails, particularly very early on, that's when the highest risk of suicide occurs. So that screening issue is particularly important. In the prisons, by the time there's a very elaborate process of classification and screening of all kinds that takes place, including medical health and mental health, so that that's an organized system that's uniform throughout the state.
Okay, and I guess you're suggesting, at least in your opinion, it works well?
I think that it does. I think that we have seen at Bridgewater, we get hundreds and hundreds of admissions a year. So simply to judge by the flow from the facilities outside of Bridgewater, there's no question that cases are being identified and help to get to higher levels of care. Furthermore, it wasn't many of those cases are also, of course, coming in from the jail. So, you know, those cases are being identified as well.
Mm-hmm. But
I think that there's always a problem in any of these settings that has to do with a number of factors, some of which actually have to do with the inmates or pretrial detainees themselves. It isn't always a good thing from the standpoint of someone who is in prison to be seeking mental health services. Sometimes inmates would rather be perceived as bad than mad, and so they may conceal symptoms of mental illness. It does carry a stigma to be identified as mentally ill in a correctional setting. There's a slang term that inmates use for other inmates who are mentally ill. They call them bugs, and they call the medications bug juice. And it's understandable why men in that situation, where your ability to carry yourself to exert an air of authority may have a lot to do with your individual safety and your ability to survive in that situation, may lead you not to want to be identified as having mental health problems.
But there are others too who want to have a mental health record to wheel and deal. I mean,
that is absolutely clear,
right.
And that is among the more difficult kinds of patients that the system deals with, are those who are capable of using their knowledge of how the system of care and referral works to obtain transfer by presenting with behavioral or mental health problems that may not be as serious as they appear.
Now, let me go back to something else you said, and this is, I know, somewhat controversial, but hypothetically. You said Bridgewater is very busy, and the admission pattern reflects the kind of screening that's going on. On the other hand, what if I told you hypothetically that there was a time, because I lived through it, where psychiatrists especially were strongly admonished for transferring patients in the correctional system to Bridgewater State Hospital, so that yes, it's busy, but it's not necessarily a measure of the extent of the problem if a lot of people aren't being transferred who, in the best of all possible worlds, may benefit from transfer.
I have no doubt in my mind, especially with my recent experience in the system, that anyone who is in need of transfer to Bridgewater is going to get there. If anything, as in every other inpatient setting, those clinicians who are in the inpatient setting tend to express more frustration about the influx of admissions and to wish that the patients maybe could be maintained in the facilities as the analogy to outpatients, simply because the flood of patients into Bridgewater can really be overwhelming at times. I think it's very important for people to be aware that mental health services in the Department of Correction now are provided by the University of Massachusetts Medical School. So what you have is an affiliation with an academic Department of Psychiatry that, in my opinion, and I have to say I've been a member of that department, delivers the highest standard of care and continues to maintain that standard within the Department of Correction. And in fact, I think that the UMass's involvement reflects what was previously in UMass a strong commitment to the public sector. UMass has a nationally renowned program in forensic mental health training and research. They have always been studying the population in the state hospitals throughout Massachusetts. And so I see UMass's involvement with the Department of Correction as an extension of an already existing mission to the public sector in Massachusetts that I think they carry out very well.
Okay. So you're hopeful, I mean, that the quality of screening, the quality of caring is adequate?
I'm not only hopeful, I'm convinced that it's adequate, and what I'm hopeful about is that it's going to get even better. In other words, I think that the involvement of UMass is liable to bring continuing improvements. And I say that not just because it's not just happening here in Massachusetts. In Connecticut, the University of Connecticut has formed a similar affiliation with the Department of Corrections there. In New Hampshire, Dartmouth Medical Center is now affiliated with the Department of Correction, so that this is a growing trend. And one of the reasons for that is that the state governments and departments of correction have begun to recognize that there can actually be advantages to affiliating with an academic center, that the likelihood that they're going to get a higher quality of care is increased, that they're going to get clinicians in there who are more likely to be dedicated to that population is increased. And certainly that has been my experience.
Of course. I mean, I don't want to sound cynical, but that was the hope after Doe v. Gone in the early 80s when McLean then was contracted to come in. They got thrown out because they didn't do much of anything. So I hope you're right. In the last minute before our break, and toward that end, do you think the University of Massachusetts is committed to having the hospital become JCHO accredited?
Definitely. And I say that because
in my lifetime,
when I was well, when I was at Bridgewater, which was up until a few months ago, I was actively involved in the accreditation process and in bringing in the kinds of resources and services that are needed to accomplish that. It hasn't been achieved yet, but I have no doubt that UMass sees that as a critical goal to its participation.
Well, we'll take a break, and then perhaps after that we'll look at sort of services, rehabilitation, coddling, and kind of, attitudes toward treating this population. So, thank you.
AT&T Broadband of Norwood and Westwood will hold a 6-week workshop in video production to train local volunteers. The workshop will teach volunteers how to use camcorders and studio cameras and also train them in lighting for the sets, creating graphics, post-production editing, and audio engineering. AT&T Broadband currently uses trained volunteers on many programs such as town meetings, high school sports coverage, the 4th of July parade, and high school graduation. Workshops are held at the AT&T Broadband Studio located on 375 Vanderbilt Avenue in Norwood. The workshops are free of charge. Volunteering your time will help bring local events and programs of interest to your community. To register for the workshop, contact Kerry Darris or Jerry Comic at the AT&T Broadband Studio at 781-769-7668. That number again is 781-769-7668.
Have you saved a life today?
I took 2 flood victims to a shelter.
I donated a day's pay to help a family that lost everything in a fire.
Have you saved a life today?
I teach a class in infant CPR.
I donated a pint of blood.
Have you saved a life today?
No, but today somebody saved mine.
The American Red Cross. Together, we can save a life.
Job Corps.
I dropped out of school and I want a better future. And obviously the future is here.
You had suggested that maybe there are problems in attitudes. Community providers of service for people who come from the correctional system or who come from Bridgewater State Hospital. I think it's very important that we address that because obviously many people like myself have to deal with discharged offenders, whether they've had psychiatric issues or not. But before we get to that, perhaps could we talk a little bit about sort of psychiatric treatment in the correctional environment? Because there's a perception that it begins to approach coddling. It's as though somehow if you make somebody a psychiatric patient, you're soft on crime and you want them to serve easy time and you want their responsibility for the crime to be mitigated. Could you perhaps talk a little bit about some of those issues?
Sure, because I think that I've experienced firsthand the full range of attitudes about that. And I emphasize that there's a range of attitudes. First of all, the professional standard, as far as the psychiatric community at large is concerned, is probably best stated in the American Psychiatric Association's standards for mental health care in prisons, where what that says is that the level of services provided within correctional institutions should be the same level of services as should be provided in the community. In other words, they're not even saying it should be what is provided in the community, but that the standard should be what is optimum for the community. Now, so far, courts have not taken professional standards as a constitutional standard for care, but increasingly, I think those kinds of views are going to be influential throughout the country. Within departments of correction, among correctional officers, other correctional personnel, I think you see a range of views, and this would be unsurprising. The stereotype is of the correctional officer who taunts or otherwise mistreats the mentally ill person. And there's no denying that that sometimes takes place. On the other hand, what I think is far more common in my experience and what has been very gratifying for me in my experience as a clinician in the system are those officers who, in fact, are interested in understanding the mentally ill, are interested in working with them, are interested in developing relationships with them. And the way that that comes about, from what I've seen, is when clinicians and officers are able to deal with one another in an attitude of mutual respect and of being open to each what the other has to say. And I think that in some ways, because mental health professionals are skilled at listening and are skilled at understanding how other people think, that are supposed to be. It may be more incumbent. It really, in some ways, may be, first of all, the responsibility of the mental health professional who's coming into that setting to really try and understand how does this system work, how do people who are involved in law enforcement and security think, and then begin to work with them around their concerns. And I think that you can accomplish a lot by doing that. The other thing that's dismaying, and you mentioned that's how mental health professionals are supposed to be. I have heard mental health professionals within the correctional system expressed some stereotypic attitudes towards correctional officers and other correctional personnel that I thought were not justified at all. I've heard correctional officers being characterized as uneducated, insensitive, all kinds of stereotypes that you would think the people talking would know better. I think really what needs to take place and what hasn't happened yet in the system is the system needs to recognize and reward those officers and other frontline personnel who demonstrate skill and motivation in working with the mentally ill. A small example is making sure, for example, on these residential treatment units, that the officers who staff those units are not rotated out in the usual fashion, but that they stay on those units. Similarly, things like that can happen within Bridgewater State Hospital and do. I know that many of the correctional officers at Bridgewater have expressed an interest in having their status as officers who work with the mentally ill recognized and promoted. There are actually union problems with that, so that the correctional officers union is wary of distinctions within. So there are attitudes that are outdated, that are backward, that can hinder care, but there are also the opposite kinds of attitudes, and I think the key is to try and promote those better than they have been in the past.
What about now switching to the attitude of providers, mental health providers working with people with a criminal justice history?
Well, I think that I'd like to start a little bit from my own experience, reflecting on the fact that when I was first training in psychiatry as a junior resident, I had no idea that I would ever find myself working with the violent and criminal mentally ill. And in fact, the very thought that I might be sitting in the same room with someone who had done something violent because of a mental illness, who was maybe overtly threatening in some way, that made me tremendously anxious and frightened. And I think that that is a very common experience for mental health clinicians of all kinds. And I think that, unfortunately, this can lead to patients who come out of jails and prisons and into the community possibly not getting the best care, or of not being able to have access to clinicians who are able to in some way understand or be open to the kind of experience that men and women who have been in prison have been through, which is of sadly experiencing a very violent and dangerous environment, and of bringing some of that with them when they come out again. So I think that one of the things that would help a great deal in that would be for the mental health clinician community at large to start to pay attention a little bit to these patients who are in the prisons and jails, recognize that they are in fact their patients, and may become their patients in the near future. Yesterday, at the meeting of the American Academy of Psychiatry and the Law, which is meeting here in Boston this year, Jeff Metzner, who's a leading proponent of mental health care in the prisons in the United States, and who's the current president of the organization, spoke about what he described as in-reach. You know, we often talk about outreach of mental health clinicians reaching out. He suggested that one thing that might help would be for mental health clinicians in the community to actually go into jails and prisons when people are transitioning out and start to develop the relationship before they even leave the institution. That this would be a tremendous advantage in improving care. And to the extent that mental illness and all of the difficulties that go along with it can contribute to someone becoming involved with the courts again, ending up being arrested again. To the extent that they can get better care in the community, it's more likely that they will not end up back in court and not end up back in the jails.
Well, it's a wonderful idea. I think that if you look at the funding streams that support outpatient programs, there's really been a fundamental change in the last 15 years. I actually got a grant recently to study some of this. My flexibility, for example, I would love to go and do some in-reaching and kind of smoothing the way for people to transition into the community. Nobody's going to pay me to do that. None of the insurers, for example, and really that's how the outpatient industry today is supported, could afford to go do that kind of in-reaching minus a grant. I mean, if you could add a grant into the mix, a grant that specifically paid experienced clinicians to do that, then I think it could happen. It's a wonderful idea. It isn't going to happen given the current funding stream.
Well, not only does the current funding stream interfere with trying to bring about something that it's hard to disagree would be helpful, but I think that the way that mental health care in general is underfunded in this country has contributed to what are increasingly perceived as higher levels of mental illness within the courts and the legal system. So although I know a number of people at UMass are researching this to try and substantiate whether it is true or not, but there is a suspicion widely held and, in my experience, justified that deinstitutionalization followed by the impact of managed care on decreasing access to services has led to public mental health officials, police, and judges in a desperate position of essentially making use of the courts to triage the mentally ill. And what will happen is that people who are mentally ill and untreated will commit some minor infraction. They'll end up in a court. They'll be held a pre-trial on some relatively small charge because there's nowhere else for them to go. They will become even worse within the jail, and then the next thing you know, they're transferred to Bridgewater State Hospital, and they are now caught up in the system of the courts and the correctional system because there was inadequate care for them in the community.
Okay, we'll take a break, and maybe we can pick up with that in terms of some thoughts you have about where we might go, practically speaking, in the near and distant future on some of these problems. Thank you.
Definitely.
For people who have to deal with the harsh realities of life, there is hope. There is Volunteers of America. Volunteers of America has been rebuilding lives and restoring hope to people in need in communities across the country for more than 100 years. Volunteers of America is one of the nation's largest nonprofit charitable organizations, providing services for children and youth, the elderly, homeless people, families, and many others. We serve the emotional, physical, and spiritual needs of more than 1.5 million people a year. Find out how you can help. Call 1-800-899-0089 today. Volunteers of America. There are no limits to caring.
Sweetheart, smoke outside now. You promised.
Okay, hon.
Sweetheart, smoke outside now. You promised.
What kind of man are you? I'm a father. Look here, my father was a father, and he smoked his brains out in the house.
Watch as he blows those smoke rings on my little red face.
You probably have asthma.
Asthma? I'm telling you, nothing's gonna happen to your kid.
Don't swear when you're lying.
know very well that thousands of kids get bronchitis, ear infections, and even pneumonia from their parents' cigarette smoke. And didn't you promise your little angels you'd smoke outside?
Hey, Daddy.
Those little devils are just so sweet.
Do the right thing.
Please, smoke outside.
Until you can stop, go out for your kids.
Take the pledge. Call 1-800-513-1157.
Okay, well, let's look at some programming ideas you might have. I mean, how do we sort of pick up on the needs? How do we provide proper caring? What are some of the things we could do? We've touched a little bit upon some of the things that need to be done, some of the things that need to be done but probably can't be done pending some funding problems. Your thoughts about where we need to take these problems in the next few years ahead?
Well, traditionally, the agenda of prison health care reform has been driven by the courts. And right now that remains true with respect to two very important issues. One actually has to do with this discharge planning issue that we were just discussing, which is that, for example, there's an ongoing suit involving Rikers Island in New York State, which is a large jail that serves the New York City area, where the basis of the suit is inadequate discharge planning for mentally ill inmates who are being discharged from the jail into the community. Fortunately, there's an incentive on the part of the facilities themselves to do some discharge planning in the hopes that it will decrease recidivism and reduce overcrowding, which is a problem for them. So that's one very important agenda. Another thing has to do with the advent of so-called supermax facilities. These are the highest level of security form of prisons. There is a wing of Walpole within Massachusetts that is of a supermax type. It's called the Departmental Disciplinary Unit, and there are whole prisons in other states. And these units are for basically those who commit crimes within correctional systems. So these are the most violent inmates within the system. Supermax facilities put inmates in 23-hour-a-day lockdown, often alone in single rooms, occasionally with roommates. They get 1 hour a day of recreation, so-called, which usually means being allowed to step out into an enclosure that may have some access to the outdoors, but may just offer some window onto daylight. And the status of mentally ill inmates in these kinds of facilities is a subject of great concern. And basically two things are emerging that need to be addressed in that setting. Either mentally ill inmates are going to have to be screened out of being placed in such facilities because it's quite clear that those facilities worsen their mental illnesses, or parallel facilities have to be developed with the same level of security that also provide programming. So that's a very important agenda that those who are involved in prison mental health reform are looking at right now. I think that actually looking at some of at how we manage patients in the community who have been involved with the courts is another area of reform that can help keep mentally ill people out of jails and prisons. And I think that taking a look at things like conditional release from state mental health facilities that will allow closer monitoring of mentally ill patients who have violent or criminal histories, making sure that they receive medication and treatment, so that...
Are you talking about like outpatient commitment?
Well, I distinguish between something like outpatient commitment and conditional release.
Okay.
Conditional release bears more similarities to a parole type of model. I think that the legal and institutional problems around the idea of outpatient commitment make that less likely to succeed. But if you were able to have patients coming out of, for example, state hospitals, and knowing that if they did not pursue the treatment that they need in the community, that they could be hospitalized inpatient again, that would be very helpful.
So that's a statute change.
That's a statute change. Right. It's a long process, but it would help, because I think it really would serve to help the mentally ill stay in the community and to stay out of the courts and to stay out of the jails and prisons.
Because right now, just again for the record, I mean, it is, as you're suggesting, a kind of an all or none thing.
That's right.
You're either in getting 24-hour care, or if you sign out and or you're discharged, you are out. Now, you may have been referred to me in South Boston, but it doesn't necessarily mean you have to keep your appointments, or there aren't necessarily sanctions. Pre-trial is a condition of probation, it works. But post-civil commitment, legally, it doesn't work.
That's right. I think another legal reform that's increasingly being looked at now also is how substance abuse problems are handled. Mm-hmm. You know, we've gone through a phase of the war on drugs in which people who were convicted of drug-related crimes are serving increasingly longer sentences. I think this also has a lot to do with the influx of mentally ill into the jails and prisons, because frankly the substance abusing population and the chronically mentally ill population overlap, and so that those who are convicted of drug-related crimes are likely also to be mentally ill. So to the extent that there is more focus on treatment for substance use problems in the community, I think, and on using treatment rather than incarceration to manage that, I also think that will help the mentally ill to be less likely to become involved. Court diversion projects, for example, this is when you have a special division of a court that when mental health or substance abuse problems are identified as more likely to be the reason that the person has been brought into the court, that they are diverted away from the criminal process and into some kind of adjudicated treatment process where there is liaison between the courts, the community mental health system, that steers these kinds of people back into treatment and some kind of containment that way, rather than sending them into jail.
But isn't that coddling? I mean, aren't you running the risk of being perceived as soft on crime? You know, if you have a mental illness, you'll get a special program?
I think that as far as the people who are trying to manage and help the mentally ill within the correctional system go, I think they would be very happy to see appropriate diversions of mentally ill people into appropriate systems of care, rather than becoming the charges of sheriff's departments or the departments of correction, who you know, are frankly overwhelmed right now with the burden of mental illness in their system. I think that there are countless infractions that may be committed by a mentally ill person that I don't think many of us would regard as serious crimes. Disorderly conduct, trespass, laws related to vagrancy, where we recognize that these are social problems for the community, but they don't require incarceration as a response, but now they often do end up with incarceration as a response because there's no way of diverting that person from the usual, pre-trial status in jail on a minor charge as opposed to back into some kind of appropriate treatment.
It is interesting, and we're going to have to wind down a little bit, but perhaps you know that the Pine Street Inn lost a major lawsuit a number of years ago against the Department of Mental Health, trying to obligate the Department of Mental Health to follow through with services to discharge psychiatric patients who ended up in homeless shelters. The Commonwealth fought the suit and won the suit, meaning Pine Street lost, or the homeless lost. Who takes responsibility for these problem areas is always an interesting question, so I'd appreciate some of your thoughts on that.
Well, my thought on that is, to the extent that there are mentally ill in prison who experience greater life difficulty and suffering than they might have otherwise, I think that actually may be our responsibility as a community. It's all very well to point to the correctional system and ways in which they have not in the past or are not now adequately serving the mentally ill and say that the suffering is the fault of the Department of Correction. But in fact, my gravest concern is that as a community, we actually prefer to have these severely mentally ill who, frankly, are often dangerous or a risk when they're having symptoms. We prefer to have them out of sight and out of mind. And ultimately, the only way that this system is going to change is if the public at large is really willing to embrace the responsibility for this population. I think there is an issue with, it's an irony. The Department of Mental Health now increasingly is managing patients who have been involved with the courts, the prisons, and the jails. 70% on average of inpatients in state hospitals in Massachusetts, these are Department of Mental Health patients, have forensic psychiatric histories. Mm-hmm. That is, they've been involved with the courts in some way or another.
Who are now civil patients.
That's right.
Mm-hmm.
And so, in fact, the Department of Mental Health now has a population that is in many ways the same as this population within the jails and prisons. That's right.
Okay.
So that this is a population that the Department of Mental Health, I think, really can no longer ignore and needs to embrace. And I think there's been some reluctance to do that.
Well, time will tell. Listen, we're going to have to stop. We've scratched the surface very generously, but it's a big problem. I appreciate your being here today. So on behalf of the Norfolk Alliance for the Mentally Ill, I want to thank you. Very much appreciate your being here.
Thank you very much for giving me the opportunity.
My pleasure.